handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Hello, kumusta? I hope you're doing well. I'm Raysa Montina, a newly licensed physician who just passed the most recent November boards. And in this video, we'll be tackling the more common pathologies involving your endocrine system, your skin, your bones and your joints, and your peripheral nervous system. Okay, so let's start. Okay, so first we'll be tackling the endocrine pathologies. Okay, so here we have a figure from Robbins displaying the different hormones that the hypothalamus secretes to act on the pituitary. So learning endocrine pathology, it's important that we have a good grasp of endocrine physiology kasi babalik at babalik kayo sa HPO axis, which is your hypothalamus, your pituitary, and your end organ. So kasi yung mga negative feedback, positive feedback, these are central concepts that will help integrate physiology and pathology and understand the clinical manifestations of the diseases. So it's also important to know the difference between your primary and secondary pathologies. Kapag sinabing primary siya, then the defect is most likely coming from the end organ itself. So kunyari, your thyroid, your parathyroid, your adrenals. Compared kapag sinabing secondary, then the defect is from the pituitary. And then minsan, may sinasabi pang tertiary dysfunction. So kapag ganon, mas mataas pa sa hypothalamus. So ulit, primary sa end organs, secondary sa pituitary, and then tertiary sa hypothalamus. Okay, so let's start with hyperpituitarism, which is a hyperfunctioning pituitary gland. The most common cause is an anterior pituitary adenoma, which we can classify based on size. So they're either macroadenomas or microadenomas. The magic number is 1 cm. So if mas malaki than that, then it's a macroadenoma. Pero if mas maliit than 1 cm, then we call it a microadenoma. And then apart from size, we can also classify it based on its hormonal activity. So if the mass produces hormones, then we call it functional. Otherwise, it's non-functional. So clinically, functional adenomas are diagnosed earlier, even at smaller sizes, because they produce hormones. Therefore, they produce symptoms in the patient. So the patient consults. This is in contrast with your non-functional adenomas, which can grow to big sizes without producing any symptoms in the patient until they get big enough that they compress adjacent structures. So the most famous one that we know is if it compresses the optic chiasm sa taas, then it produces bitemporal hemianopia. So in contrast, we have hypopituitarism or a hypofunctioning pituitary gland. So here is a list of common causes, most notable being tumors, trauma, surgery, pituitary apoplexy wherein there is infarction of the blood supply to the pituitary gland, Sheehan syndrome, seen in pregnant patients, and then you have your Raschke cleft cyst and empty sella syndrome, which can be congenital defects. So the clinical manifestations of a hypofunctioning pituitary gland will vary depending on the specific hormones that are affected. So ano-ano ba yung mga symptoms sa mga different disturbances in hormone production? So for example, TSH, which is your thyroid stimulating hormone, excess will cause increase in basal metabolic rate. So you have your symptoms of thyrotoxicosis, which we'll discuss later. In contrast, if you have decreased TSH, then you have fatigue, constipation, weight gain, cold sensitivity, parang hypothyroidism. Then next we have prolactin. So an excess of prolactin will cause amenorrhea, galactorrhea, infertility. Meanwhile, deficiency will cause a lack of breast milk production. So in ACTH, which is your adrenocorticotrophic hormone, Excess levels will cause Cushing syndrome and hyperpigmentation, while deficiency will cause severe fatigue and hypotension. And then for your growth hormone, an excess will cause gigantism, acromegaly, and impaired glucose tolerance, while deficiency will cause fatigue, muscle weakness, and in children, growth problems and short stature. So last we have FSH and LH. An excess in these hormones will cause amenorrhea, galactorrhea, infertility. Meanwhile, deficiency will cause hot flashes, decreased pubic hair, and also loss of libido. So from anterior pituitary, let's now go to our posterior pituitary syndromes. First, let's remember what hormones yung sinisecrete ng posterior pituitary. There are two. So first is your ADH or your antidiuretic hormone or vasopressin, and your second is oxytocin. So kapag you have excess ADH, you have syndrome of inappropriate ADH, which is characterized by hyponatremia, cerebral edema, and neurologic dysfunction. So remember that ADH, antidiuretic hormone, it keeps water in. So when you keep water in, nadidilute yung mga electrolytes natin, producing hyponatremia. This is in contrast with diabetes insipidus, wherein you have deficiency of ADH. So kapag ganon, then you are throwing water out. You have decreased water reabsorption in the kidney. So this manifests with polyuria, and because mababa yung water mo sa body, then parang nagko-concentrate yung mga electrolytes natin, so you have increased serum osmolality and increased serum sodium. So kapag diabetes insipidus, you have to find out the underlying mechanism and classify it based on central diabetes insipidus ba siya or nephrogenic diabetes insipidus. Kapag sinabi nating central diabetes insipidus, mababa yung pag-secrete ng pituitary ng ADH. So you have low serum ADH. Pero kapag nephrogenic diabetes insipidus siya, nephrogenic meaning galing sa kidney yung dysfunction natin. So, normal yung pag-secrete ng pituitary ng ADH, pero yung kidney ngayon, it's resistant to the actions of ADH. So, parang hindi siya nasi-stimulate ng normal levels of ADH. So, in labs, kapag central diabetes insipidus, mababa yung serum ADH, pero kapag nephrogenic diabetes insipidus, your ADH levels could be normal or even elevated. So magbabago yung management mo depending if it's central or nephrogenic. Okay, so that's for the pituitary gland. Now let's jump over to the thyroid. But first, let's differentiate thyrotoxicosis from hyperthyroidism. When we say thyrotoxicosis, this is the hypermetabolic state caused by increase in free T3 and T4. So, kapag free hormones sila yung active form. This is most commonly caused by hyperthyroidism, which is your hyperfunctioning pituitary gland. But this is not always the case. Thyrotoxicosis can be caused by excessive release of your preformed thyroid hormones, like in the case of thyroiditis, or the hormones could not be coming from your thyroid gland at all. So in summary, thyrotoxicosis may be caused by hyperthyroidism, but this is not always the case. So let's start with Graves' disease, which is the most common cause of endogenous hyperthyroidism. So this is an autoimmune disorder with autoantibodies against the TSH receptor. The most common kind of autoantibody is a thyroid-stimulating immunoglobulin. So what happens is there is continuous activation of the receptor, and so yung thyroid natin produce ng thyroid hormones. So upon examination of the thyroid gland, there is diffuse hypertrophy, so symmetric enlargement with beefy red parenchyma, and then under the microscope, we also have hypertrophy and hyperplasia of the follicles with lymphoid infiltrates. And then if you notice dito sa borders ng follicles, medyo scalloped yung appearance niya. So this is actually because the epithelial cells resorb the colloid kasi they're producing thyroid hormones. And then a special feature of Graves' disease is your Graves' ophthalmopathy and dermopathy. So, di ba may proptosis, exophthalmos. So, this is caused by your fibroblast activation. Kasi your fibroblasts also have TSH receptors. So, nasa-stimulate din sila ng mga autoantibodies. And what happens is when they're stimulated, they produce your extracellular matrix. And then kapag dumami yung extracellular matrix, nag-deposit, this is what causes the puffy appearance of your eyes and of the legs. Okay, so for hypothyroidism, we have primary and secondary causes. For primary, it could be congenital, autoimmune, or iatrogenic in cases of thyroid surgery. And then if secondary, then the pathology is with the pituitary or the hypothalamic. So may deficiency in the secretion of TSH or TRH. A special entity that we have to watch out for is cretinism, which is hypothyroidism that develops in infancy or early childhood, mostly due to iodine deficiency. So we know that iodine is central for the development of the central nervous system. So kapag kulang to, then the infant will present with severe intellectual disability, short stature, coarse facial features, protruding tongue, or umbilical hernia. This is in contrast with your myxedema, which has a more insidious onset seen in older children or adults. So what is the underlying mechanism of the manifestations of hypothyroidism? Basically, your metabolic rate is decreased. So slow organ function, you have poor memory, poor hearing, slow pulse rate, delayed reflexes, fatigued, weight gain with poor appetite, and you also have myxedema due to your deposition of the connective tissue elements, especially your glycosaminoglycans, combined with water retention. Okay, now we move to thyroiditis, so inflammation of the thyroid basically. So the most common is Hashimoto thyroiditis, which is the most common cause of hypothyroidism in places with sufficient iodine stores. So yung dysfunction dito is that you have antibodies against your thyroid peroxidase and thyroglobulins. So this destroys your thyroid cells, and on microscopy, you have atrophic thyroid follicles with Hürthle cells. So in this picture, we see that there are lymphocytic infiltrates here on the right, and then dito sa left yung what's left of the normal thyroid. So within the lymphocytic infiltrates, meron pang mga germinal centers. So, yung clinical manifestations of Hashimoto's is first you have a transient hyperthyroidism kasi due to inflammation, nagre-release yung thyroid cells ng mga preformed hormones nila as they're being destroyed. But then, kapag na-permanently destroy na sila, then you will present with hypothyroidism and that becomes permanent. Other causes of thyroiditis is your subacute lymphocytic thyroiditis, which is also called your painless or silent thyroiditis. So here you have antibodies against thyroid peroxidase, anti-TPO, and patients also frequently have family history of other autoimmune diseases. So on histology, you also see patchy lymphoid follicle formation. So may lymphoid infiltrates pa rin. And then next we have granulomatous thyroiditis, which is your painful or decurvane thyroiditis. This is the most common cause of thyroid pain or neck pain, and usually our patients will have history of a prior upper respiratory tract infection. So the hypothesis is that the antigen from the infection stimulates your cytotoxic T cells. So these are your CD8 T cells, which damage the thyroid follicles. And sometimes on histology, you see granuloma. So ito may multinucleate giant cell. So this is your normal colored follicle. Okay, let's discuss thyroid neoplasm. So you could have a thyroid adenoma, which is a benign, discrete, solitary, encapsulated mass. So important dito is that the capsule should be well defined and intact kasi otherwise, this could be more suspicious for a carcinoma. So majority of your thyroid adenomas are non-functional, meaning hindi sila nagproproduce ng thyroid hormones. And they arise due to gain of function mutations in the following genes. So here we have on the right a thyroid follicular adenoma. So you see that it's a solitary, well-circumscribed nodule, and then on histology, well differentiated pa yung follicles. So kamukha pa nila yung normal thyroid parenchyma. This is in contrast with your carcinomas. So we have four types: your papillary, follicular, and anaplastic, which are derived from follicular epithelium. And the other type is your medullary, which arises naman from your parafollicular C cells, which secrete calcitonin. So these carcinomas, they have different genetic alterations here in the table, depending on the type. And then our risk factors for carcinoma include iodine deficiency or exposure to ionizing radiation, as well as family history. And then let's go to our congenital thyroid anomalies. So we have the thyroglossal duct cyst, which is a persistent sinus tract as a vestigial remnant of the thyroid gland. So ito yung most common congenital anomaly of the thyroid. And then we usually see them in children who present with a neck mass. The problem here is that there could be superimposed infection. So nagiging parang collection of abscess yung thyroglossal duct cyst. And that's usually when they come for consult kasi nagkaka-fever, pain, and other symptoms. Okay, so let's start with our parathyroid glands. So let's remember that PTH, your parathyroid hormone, is secreted in response to low levels of serum calcium. So kapag primary hyperparathyroidism, it's usually due to a parathyroid adenoma or hyperplasia of the parathyroid glands or carcinoma. Pero kapag sinabi mong secondary hyperparathyroidism, is usually due to chronic hypocalcemia due to chronic kidney disease or vitamin D deficiency. So whether it's primary or secondary hyperparathyroidism, it still presents with your stones, so your kidney stones, thrones, polyuria, bones, groans, abdominal pain, and psychiatric overtones. So you have neuropsychiatric disturbances. And then on X-ray, we might see osteitis fibrosa cystica. So here, so you have cystic bone spaces filled with brown fibrous tissue. So this consists of your osteoclasts and deposited hemosiderin from hemorrhages. So that's what causes your bone pain. So in contrast, kapag hypoparathyroidism is usually due to accidental removal of the parathyroid glands during thyroid surgery, or it could also be autoimmune. So in contrast naman, yung mga manifestations ng hypoparathyroidism, you have tetany, neuromuscular irritability, and circumoral numbness. So the two signs characteristic of hypocalcemia, you have your Schwostek sign, which is a facial spasm when you tap the cheeks, and then Trousseau sign, which is carpopedal spasm when you compress the arm, kunyari with a BP cuff. Okay? Okay, so from our parathyroids, let's head over to the endocrine pancreas, and the main pathology we'll focus on here is diabetes mellitus, which is hyperglycemia due to defects in insulin secretion or action. So we have two types, your type 1 and type 2, and type 1 is autoimmune destruction of the beta cells. Meanwhile, type 2, you have increasing resistance to insulin by the peripheral tissues. So this leads to progressive beta cell failure. So in terms of clinical manifestations, type 1 will present in younger patients, and then type 2 will present in our older patients along with the other non-communicable diseases and obesity, which type 2 is more associated with. It's notable that genetic predisposition is relatively stronger in type 2. However, the association with your HLA, DR4, and DR3 is present with your type 1. So also the classic symptoms of your triad, yung polyuria, polydipsia, polyphagia, mas common siya actually sa type 1 diabetes mellitus. And then on histology, since type 1 is an autoimmune type of destruction by your CD4 T cells, you have insulinitis here. So ito yung mga lymphocytic infiltration due to the inflammation. Meanwhile, kapag type 2, you have amyloid deposits naman interspersed throughout the beta cells here. Okay, but how does high blood sugar damage our peripheral tissues and contribute to the long-term complications of diabetes? So there are four mechanisms currently being discussed. First is the formation of advanced glycation end products, which are products of glucose metabolism that can bind to our proteins and cause deposition as well as activation of inflammatory cells. The second is by activation of protein kinase C, which also increases VEGF activity, TGF-beta, and other cytokines and mediators. The third is by oxidative stress and disturbance in polyol pathways. So ito yung nangyayari sa mga nerves, lens, kidneys, and blood vessels kapag nag-accumulate yung sorbitol and nagkakaroon ng oxidative stress kasi nauubos yung NADPH and reduced glutathione, which we need as an antioxidant. And then the fourth is by your hexosamine pathways and fructose 6-phosphate generation, which also contributes to cell damage and enhanced oxidative stress. So these are the long-term complications of diabetes. So we have both microvascular complications like your retinopathy, nephropathy, and neuropathy, as well as the macrovascular complications like your myocardial infarcts and your cerebrovascular infarcts. Okay, so from our endocrine pancreas, let's head over to our adrenal glands. Our first disease entity is Cushing syndrome, which is a set of symptoms due to increase in cortisol, so hypercortisolism. So this could be from endogenous or exogenous sources of excess cortisol. Yung most common source is a exogenous source, so kapag may long-term use ka of your steroids here. And then other causes could be pituitary tumors. So when you do have a pituitary tumor, then you call that Cushing disease versus yung Cushing syndrome, which is the set of symptoms. Otherwise, you could have an ectopic ACTH-producing tumor or an adrenal tumor. So these are the symptoms of Cushing syndrome. We are familiar with them. Moon face, buffalo hump, muscle wasting, stretch marks, weight gain, and obesity, which is the most common symptom. So other manifestations of a hyperfunctioning adrenal gland, you could have excess aldosterone, which could be primary or secondary in nature. Kapag primary, pwedeng idiopathic or due to Conn syndrome. Pero kapag secondary, due to activation of your renin-angiotensin-aldosterone system. So clinically, this will present with hypokalemic hypertension and metabolic alkalosis. And then another entity is your adrenogenital syndrome, in which you have excess adrenal sex hormones due to neoplasms or congenital adrenal hyperplasia or your CAH. So kapag CAH, you could have a deficiency in the following enzymes. So your 21-hydroxylase, which is the most common, your 11-hydroxylase, or your 17-hydroxylase. So CAH could be salt wasting kapag mababa yung aldosterone or simple virilizing. So kapag 21, for example, 21-hydroxylase deficiency, there is a block in this pathway. So yung mga substrates na to, nasashunt sila towards the production of your testosterone and other sex steroids. So mataas yung sex steroids mo, pero mababa yung aldosterone and cortisol. So there is salt wasting. So this is what we call classic CAH. So kapag hypofunctioning adrenal gland naman, we can separate it into primary and secondary causes. So pag primary, galing siya sa adrenal gland mismo. Pero kapag secondary, the dysfunction is in the pituitary or the hypothalamus. So these could be the possible causes for that. Pero kapag primary, we can further subdivide it into acute and chronic processes. Kapag primary acute, ito yung tinatawag na adrenal crisis, and it could be triggered by stress, exogenous steroids, or adrenal hemorrhage, which is most particularly found in Waterhouse-Friderichsen syndrome, which is caused by your Neisseria meningitidis infection. Kapag primary chronic hypoadrenalism naman, this could be caused by autoimmune adrenalitis, especially in the developed world. Pero in other parts of the world, it could still be due to infectious causes, for example, TB. So here in this slide, we can see that the adrenal cortex has a lot of hemorrhage with some sparse normal tissue left. Okay, so from the adrenal cortex, now let's go to disorders of the adrenal medulla. Most prominent is your pheochromocytoma, which is a neoplasm composed of chromaffin cells. So remember, kapag pheochromocytoma, yung memory aid natin is your rule of 10. So 10% of pheochromocytomas are extraadrenal, 10% are bilateral, 10% are biologically malignant, and 10% are not associated with hypertension. And then 25% of pheochromocytomas have a germline mutation in the following genes. And then histologically, we see clusters of polygonal to spindle-shaped cells or chief cells with sustentacular cells, which creates small nests or alveoli, which are called your zellbollen. So, meron kang nest of cells with abundant cytoplasm. Then now let's go to our multiple endocrine neoplasia or your MEN syndromes, which are inherited disorders. And when you compare it with their sporadic counterparts, they present in patients of younger age. And then multiple endocrine organs are involved. And even just in one organ, pwedeng multifocal pa siya. Tapos, yung mga tumors nito, they are more aggressive and they are more likely to recur. So kapag MEN1, it presents with your pituitary adenoma, parathyroid hyperplasia, and your pancreatic tumors. And then your MEN2A and your MEN2B, they have in common your medullary thyroid carcinoma and your pheochromocytoma. What sets apart MEN2A from 2B is that it has parathyroid hyperplasia. And then yung 2B naman, it has mucosal neuromas and a marfanoid body habitus. Okay, so last for completion is the pineal gland. So tumors involving the pineal gland are rare, such that it's not really discussed in Robbins. And then these tumors are arising from sequestered embryonic germ cells. And they take the forms of your germinomas. So parang similar siya to your seminomas in your testicles. And then a pinealoma could be a pineoblastoma or a pineocytoma based on the degree of differentiation. Okay, now let's move on to our skin pathology. Okay, so let's start with our nevi. We have your melanocytic nevus, which is commonly termed your moles, which are benign lesions. So they should have well-defined round borders and they do have multiple variants. So for example, your junctional and your compound. Pero in contrast, your dysplastic nevi, they can be direct precursors of melanoma. And kapag marami sila, it could also incur an increased risk of melanoma due to inherited mutations in the CDKN2A gene. So compared to your melanocytic nevus, they are larger than most acquired nevi and they tend to present in multiple. So hindi siya isa-isa lang. Okay, so here in the first row, we have melanocytic nevi. Here in the left is a junctional type, and then here in the right is a compound type. Tapos dito naman sa second row is your dysplastic nevus. So you see they are multiple compared to yung mga solitary natin na moles. And the borders are not so well defined compared to our melanocytic nevi. So from our nevi, we go on to melanoma, which is the deadliest of all the skin cancers. So majority are due to UV radiation damage from sunlight. And it progresses in two phases. Yung radial phase where it spreads out and then vertical phase where it grows deeper into your epidermis and dermis. So the most important prognostic factor is tumor depth, which can be measured by your Breslow thickness. Which is the distance from the most superficial epidermal cell layer to the deepest part of the dermis wherein you still find tumor cells. So, syempre, if mas deep yung tumor mo, then it is less favorable or parang mas poor prognosis siya kasi it's more likely to metastasize. So, we have different types. For example, here in the first row is a superficial spreading type. So you can see that it's not particularly deep, pero mas haba yung radial face niya ng pag-grow compared to the vertical face. So this has a better prognosis compared to the type here in the bottom, which is your nodular melanoma. So you see na parang nag-umbok siya more than spreading out. So you can infer na mas matagal siya sa vertical face than the radial face. And that confers a poorer prognosis because it means that the tumor is deeper. So here we have a melanoma. So the typical lesions have irregular contour and pigmentation. And they're usually asymptomatic kasi people think that they are just, your benign moles. Pero sometimes they can present with itching or pain. So clinically, what we have to remember is the ABCDEs of your skin lesion. So is it symmetric? A for asymmetry, B for border, C for color, D for diameter, is it more than 6 millimeters, and E for evolution over time. Okay, now let's discuss our benign epithelial tumors, which are derived from keratinizing stratified squamous epithelium, as well as the hair follicles and other ductular epithelium of the cutaneous glands. So they are mostly sporadic, pero sometimes they can be associated with syndromes that have worse malignancies. For example, Cowden syndrome, which presents with multiple tricholemomas, or Muir-Torre syndrome, which presents with multiple sebaceous neoplasms. Okay, so first we have seborrheic keratosis, which presents with a round, flat, waxy plaque with a velvety to granular surface with pore-like osteas, parang maliliit na butas sa surface. So when you have multiple seborrheic keratosis, this could be your lesser Trelat sign, which is indicative of an underlying gastrointestinal malignancy. So next is your acanthosis nigricans, which is your thickened, velvety, hyperpigmented skin in the flexural areas, more commonly in the back of the neck, in the intertriginous areas. So this could be familial, or it could also be paraneoplastic for an underlying GI malignancy again. So the third is a fibroepithelial polyp, which is also called an acrocordon or skin tag. So they are soft, flesh-colored bag-like tumors attached by a slender stalk and could be associated with Birt-Hogg-Dubh syndrome. And then the fourth is an epithelial or follicular inclusion cyst, which is an invagination or cystic expansion of the epidermis or hair follicle. So when it ruptures, it could be foul-smelling and it can become painful with a granulomatous response due to your chronic inflammation. And then now from our benign, let's go to our pre-malignant and malignant tumors. So the first is actinic keratosis, which arises due to exposure to sunlight, UV light, ionizing radiation, and arsenicals or industrial hydrocarbons. This could progress to squamous cell carcinoma, this one, which is the second most common tumor on sun-exposed sites. So like actinic keratosis and the next basal cell, lahat sila may risk factor na UV light exposure. So if it is in situ, meaning hindi pa siya nag-invade sa dermo-epidermal junction, it looks like a sharply defined red scaling plaque. Pero if mas nag-progress na siya, it could look like this, like a nodular hyperkeratotic scale. And then next we have our basal cell carcinoma, which is the most common invasive cancer in humans. So it is locally aggressive and slow growing, so it rarely metastasizes. And clinically, it can look like a pearly papule with telangiectasia or capillary dilation that can ulcerate. So yung tinatawag nila na rodent ulcers, that is your basal cell carcinoma. So for our acute inflammatory dermatosis, first we have urticaria, which is a localized mast cell degranulation resulting in dermal hyperpermeability. So these lesions, which we call our wheals, which will develop and fade within hours. And then due to the hyperpermeability, may edema dun sa tissues, which we can see here. Then next, we have acute eczematous dermatitis. So this is a T-cell mediated inflammatory reaction. So these lesions appear as red, papulovesicular, oozing, and crusted lesions. And then if it persists, it can result in reactive acanthosis and hyperkeratosis. So parang nagiging scaling plaque siya kapag naging chronic. And then next we have our erythema multiforme, which is a self-limited hypersensitivity to certain infections and drugs. So this is a hypersensitivity mediated by your CD8 cytotoxic T cells. So yung most characteristic na lesion here is the targetoid lesion. Pero it can present with other types of lesions, kaya nga multiforme yung pangalan. So maraming forms. And then our SJS, Stevens-Johnson syndrome, and your toxic epidermal necrolysis, these are variants of erythema multiforme. And then for our chronic inflammatory dermatosis, first we have psoriasis, which is also an autoimmune disorder mediated by your CD4 and CD8 cells. So these appear as well demarcated, pink to salmon-colored plaques, covered by loosely adherent silver-white scales, mostly on your extensor surfaces like your knees and your elbows. So important signs for psoriasis is your Koebner phenomenon, which is the induction of your lesions on areas of trauma in the skin. And then Auspitz sign is bleeding whenever you pick off the scales, and then your Monroe microabscesses, which you can see on histology. And then next is your seborrheic dermatitis. So we have macules and papules on erythematous yellow, often greasy base with scaling and crustings. So if found on the scalp, it's called dandruff. And then on histology, you can see follicular lipping. And then third is lichen planus. So ito yung 6 P's natin na pruritic, purple, polygonal, planar, papules, and plaques. So ito yung itsura niya. It's purple, it's polygonal, it's planar, and it can be a papule or a plaque. So it is distributed on the extremities, so marami yan usually in a symmetric fashion. And then in our oral mucosa, you can see Wickham's striae, parang white, thin white lines. And then in histology, you can see sawtoothing, or colloid and civet bodies. And then now let's go to our blistering diseases. So we have 3, your pemphigus, pemphigoid, and dermatitis herpetiformis. So iba-iba yung ina-attack nilang connections in our epidermis. So kapag pemphigus, you have autoantibodies against desmoglein, which is present in your desmosomes, in between the cells. And then kapag pemphigoid naman, you have autoantibodies against the hemidesmosome, which anchor your basal cells to the basement membrane. Tapos, your dermatitis herpetiformis, it has autoantibodies against your anchoring filaments here. So first is your pemphigus, and then the most common variant is your pemphigus vulgaris, your most common type. So you will have lesions in both the skin and the oral mucosa. And then on immunofluorescence, you have lace-like pattern kasi your autoantibodies nga attack your desmosomes, which are found between the cells of the layers. So this will all light up kasi lahat yan may autoantibodies against desmoglein. So pemphigus vulgaris, it's the more severe of the 3 kasi the blisters are more likely to rupture. So that can lead to dehydration. And then next is your bullous pemphigoid. So here you have autoantibodies against the hemidesmosomes in the basement membrane. Kaya compared to your pemphigus vulgaris kanina, ito lang yung magla-light up, yung area sa may basement membrane. Kasi yung autoantibodies niya, ito lang yung ina-attack niya. So you have a linear pattern on immunofluorescence. So compared to pemphigus vulgaris, the bullae here are tense. They do not easily rupture. And they heal, pero may scarring nga lang. Then third is your dermatitis herpetiformis, wherein you have IgA antibodies to dietary gluten. So when we say gluten, what immediately comes to our mind is celiac disease, diba? Kaya may association din siya with celiac disease. And then our lesions are extremely pruritic, grouped vesicles on the extensor surfaces. And then on immunofluorescence, medyo similar siya sa bullous pemphigoid kasi dito siya sa may basement membrane. Pero in contrast, you have microabscesses due to fibrin and neutrophil accumulation at the tips of the dermal papillae. Now, for the disorders of epidermal appendages, first, clinically relevant is your acne vulgaris, which is characterized by your comedones. So you can have open comedones, which are termed your whiteheads, or your closed comedones, which are your blackheads. So there are multiple factors as to why a person can develop acne. First is the development of a keratin plug. Second is hypertrophy of the sebaceous glands. Third is bacterial colonization, especially with Propionibacterium acne. And fourth is your secondary inflammation kapag may superimposed bacterial infection. And then rosacea, you have high cutaneous levels of cathelicidin, which is an inflammatory mediator. So it presents during middle age and is more common in females. Next, we have panniculitis, which are inflammatory reactions in the subcutaneous adipose tissue. So the first type is your erythema nodosum, which is a delayed type of hypersensitivity associated with infections, drugs, cancers, and then these present with poorly defined tender erythematous plaques and papules. So another is your erythema induratum, which is a vasculitis of deep vessels which supply the fat lobules of the subcutis. So these present in our adolescent and menopausal women. And then on histology, there is granulomatous inflammation and zones of caseous necrosis because of vasculitis. And then last, we have our skin infections. First is our verrucae or warts, which are squamoproliferative disorders caused by human papilloma virus, most commonly by variants 6, 11, 16, 5, and 8. So they are common in children and adolescents, but they are self-limiting. And then these verrucous or epidermal hyperplasia will have coilocytosis as the histologic characteristic. Next is molluscum contagiosum, which is a self-limited disease caused by pox virus. So you have firm, pruritic, pink to skin-colored umbilicated papules. So umbilicated yung characteristic lesion niya. And then on histology, you will see molluscum bodies. And then pag impetigo naman, this is a superficial bacterial infection caused by Staph aureus or your group A strep or your strep pyogenes. So the innate immune response causes epidermal injury, which leads to a serous exudate and scaling of the crust. So kapag nag-crust over na yung lesions, it is honey-colored. Remember, Staph aureus is golden, so you can correlate it na rin with neutrophilic infiltrates. And kapag superficial fungal infections naman, these can be caused by your dermatophytes or malassezia for fur, which causes tinea versicolor. Okay, so after skin pathologies, let's now go to our bones, joints, and soft tissue tumors. Okay, so let's start with our bones and our congenital diseases. So first is osteogenesis imperfecta, which is the most common inherited disorder of connective tissue. So autosomal dominant inheritance siya, and you have deficiencies in type 1 collagen synthesis. So we know that type 1 collagen is the major component of bone. So when you have deficiencies in type 1 collagen, your bones are extremely fragile. So you have 8 types. Type 1 yung may blue sclera, but type 2 is the most lethal form presenting with intrauterine demise of the fetus. So here in the left, we have an X-ray of a fetus with type 2 osteogenesis imperfecta. So mukha siyang batak, pero actually this is because virtually all the bones have numerous fractures, resulting in accordion-like shortening of the limbs. Okay, so next is osteopetrosis, which is autosomal recessive deficiency in osteoclast function. Kaya ano bang ginagawa ng osteoclast natin? Diba? They reabsorb bone for remodeling. So if hindi yun nagagawa, then what happens is there is reduced bone resorption. And clinically, they present with diffuse symmetric skeletal sclerosis. However, this sclerotic bone is brittle and it fractures easily. And then on X-ray, you see an Erlenmeyer-Flask deformity. And then here we have acquired disorders of the bone. So osteoporosis is adult onset, decrease in bone mass or density. So imbes na bone yung laman, the bone marrow is actually replaced by fat. So risk factors include increasing age, decreased physical activity, female sex, low diet of calcium and vitamin D, hormones, and of course genetics. And then osteomalacia and rickets is reduced bone mass due to vitamin D deficiency. And then for renal osteodystrophy, these are bone changes in patients with renal failure because there is decreased tubular, glomerular, and hormonal renal functions. And then in Paget's disease, the bone mass is increased, pero yung pag-increase niya, hindi siya maayos, disordered, and structurally unsound. So this also presents in late adulthood, and clinically or histologically, you see a mosaic pattern of lamellar bone, cement lines, and abnormally large. Okay, so next we have fractures, which are due to a loss in bone integrity. And an important concept that we have to understand is the stages of fracture healing and the different cells that play a part in the different stages. So for the first day after the insult, generally we have an organizing hematoma. If maayos yung pag-immobilize ng two ends of the bones, then the organizing hematoma will provide inflammatory cells that aid in fracture healing. So kapag within the next 2 weeks, your platelets and your inflammatory cells from that organizing hematoma will provide cytokines and growth factors that promote the formation of a fibrin meshwork. So dito sa fibrin meshwork, dun na gumagalaw yung mga osteoclasts and our osteoblasts and chondrocytes which produce cartilage and bone. So with adequate immobilization and proper management, the soft callus that forms in the first 2 weeks will eventually convert into a bony callus, which will remodel into normal lamellar bone in a couple of months. Okay, next let's move to infections of the bones. That's osteomyelitis. So it could be bacterial, mycobacterial, or syphilitic in origin. Kapag sinabing pyogenic or bacterial, the most common agent is your Staph aureus. So kapag pyogenic, of course, it's bacterial, so you would see neutrophilic infiltrates. And then this is where you will encounter the terms involucrum and sequestrum. So your sequestrum is the dead bone, the necrotic bone due to inflammation and infections, and this can crumble and release fragments. But as inflammation evolves, your chronic inflammatory cells will be recruited, and this will stimulate bone resorption and parang reactive bone formation in response to the necrosis. So the new bone is the involucrum, and it forms a shell around your sequestrum. So yung sequestrum is sequestered inside the involucrum. And then next is your mycobacterial osteomyelitis, most commonly due to TB pa rin. So you will notice that it is more destructive and resistant to antibiotic control. And then histologically, you will see still granuloma formation kasi mycobacterium pa rin naman to. And Langhans multinucleated giant cells. And then kapag syphilitic naman yung origin niya, it could be due to congenital syphilis or acquired syphilis. And then kapag acquired siya, it's usually during the tertiary stage of syphilis. Kapag congenital, aside from your osteomyelitis, you will see deformities like your saddle nose deformity or your saber shin. Pero kapag acquired siya, it usually happens 2 to 5 years after the initial infection. It will involve the nose, the palate, the skull, and the extremities. And then yung pattern of inflammation niya, you will see coagulative necrosis and gumas, as is typical for a tertiary syphilis. And then next we go to our bone tumors. So what's important when differentiating bone tumors is the patient's age, the x-ray of the patient, their clinical symptoms. So for example, we have osteosarcoma, which is the most common primary malignant tumor of the bone. So yung age distribution niya, we can find it both in the younger patients, less than 20 years old, and in our older patients. And it most commonly presents in the knees and metaphysis of the long bones. So on X-ray, we can see Codman's triangle here, which is actually reactive periosteal bone formation. So parang the tumor is actually here inside, pero as it expands, it lifts off your periosteum, forming Codman's triangle. And this is indicative of an aggressive tumor. So the malignant tumor cells are bone forming. They produce unmineralized osteoid or mineralized bone. And then here, in a gross specimen, we can see how the tumor cells here actually lifts off and invades outside the bone na. And then this is in contrast to a Ewing sarcoma, which is the second most common bone malignancy in children. So it arises from abnormalities in chromosome 11 and 22. So kapag sinabing T1122, that's Ewing sarcoma. And then it's neuroendocrine cell in origin, contrasted with yung osteosarcoma, which is derived from your bone-forming cells. And then in X-ray naman, yung pattern niya is an onion skinning pattern and salt and pepper appearance on histology. So ito yung mga small blue round cells or yung primitive cells that you see in Ewing sarcoma. So usually yung osteosarcoma at yung Ewing sarcoma yung pinagdi-differentiate. So kapag osteosarcoma, it arises from the metaphysis. Kapag Ewing sarcoma, diaphysis of the bones or the shaft. Kapag osteosarcoma, Codman's triangle, Ewing sarcoma, onion skinning pattern. Okay, and then next is our metastasis, which is the most common tumor in the bone for adults. So contrast this, kapag metastasis, sila yung most common tumor in the bone, pero osteosarcoma is the most common tumor arising from the bone itself. Okay, so the most common sources for metastasis to bones is in females from breast cancer, and then in males from prostate cancer, and then from lungs, kidney, and thyroid cancers. Okay, let's start with our joint pathology, starting with our arthritis. So osteoarthritis is primarily a degenerative process. So it really comes with old age and constant use of our joints, in contrast with a rheumatoid arthritis, which is autoimmune. So kapag autoimmune siya, it has more inflammation, and we see an inflammatory pannus in rheumatoid arthritis. A pannus is a mass of synovium, inflammatory cells, granulation tissue, and fibroblasts that causes erosion of the articular cartilage. Habang yung osteoarthritis naman, you don't see a lot of inflammation at the start, so it could be secondary na lang when the inflammatory mediators exacerbate the damage of the cartilage. And then, since it's a degenerative process, it affects primarily the weight-bearing joints kasi these joints have the most load, have the most stress. So these are your knees and hips. In contrast with your rheumatoid arthritis, wherein the joints, often the inflammation begins in the small joints of the fingers, and then it gradually progresses to larger joints. So rheumatoid arthritis has serum antibodies like your anti-citrulline protein and your rheumatoid factor. And since it's autoimmune, it's a systemic disease, so it can affect your lungs, your heart, and your other organs. So these are what you can find in rheumatoid arthritis and osteoarthritis. So kapag osteoarthritis, you can see bony spurs, pero walang ankylosis. The ankylosis happens in rheumatoid arthritis lang, because as the pannus gradually erodes the cartilage, kapag chronic na yung inflammation, it becomes fibrous, and then kapag hindi pa rin nagsiseize yung inflammation, magiging bony ankylosis na, yung fibrous na ankylosis. So other findings that we see in osteoarthritis are subchondral cysts, sclerosis, osteophytes, and a thinned and fibrillated cartilage. Next, we have juvenile idiopathic arthritis, which is arthritis that starts before 16 years of age and persists for at least 6 weeks. So 16 years old, 6 weeks. So the pathogenesis and the cause are unknown, but this is associated with oligoarthritis, systemic disease, and large joint involvement. Next, we have our seronegative spondyloarthropathies. So, compared to sa mga arthritis kanina, in these diseases, walang rheumatoid factor, and then the pathologic changes are found in the ligaments and not in the synovium. It also frequently involves the sacroiliac joint, and there is association with HLA-B27 as well as formation of your bony ankylosis. So our first disease entity here is your ankylosing spondylitis, which usually involves the sacroiliac joint as well as the vertebra. So it presents with low back pain and spinal immobility, especially in the second to third decades of life. And this is classically associated with HLA-B27 as well as a bamboo spine finding on X-ray. And then next we have reactive arthritis, which is our triad of arthritis or urethritis or cervicitis and conjunctivitis following an infection. Next, we have our infectious causes of arthritis. So when we say suppurative, para siyang pyogenic osteomyelitis, commonly caused by Staph aureus, additionally by Neisseria gonorrhea, especially in young adults, and Salmonella in patients with sickle cell disease. So it's characterized by a sudden onset of an acutely painful and swollen joint with constricted range of motion, as well as fever and high WBCs or leukocytosis. TB is also another common cause of infectious arthritis. So it's a more chronic, progressive infection that affects only one joint, monoarticular. Most commonly affects the weight-bearing joints, again, the hips, the knees, and the ankles. We also have viral agents like your parvovirus, B19, rubella, hepatitis B and C, as well as Lyme arthritis, which is caused by your Borrelia burgdorferi. So this is a migratory type of arthritis that lasts weeks to months and involves the large joints like the knees, the shoulders, the elbows, and the ankles. Okay, so next we will move on to our crystal-induced arthritis. So this is mainly gout and pseudo-gout. So in gout, the main insult is hyperuricemia. And then hyperuricemia will induce the precipitation of the monosodium urate crystals into the joints. And then these monosodium urate crystals, they will stimulate macrophage and neutrophil activation. And with that, cytokine release and further inflammation. So gout has 4 patterns. It could present with acute arthritis. So this is the sudden onset joint pain with localized hyperemia and warmth, and most commonly presenting in the first metatarsophalangeal joint of the big toe. Second is the chronic tophaceous pattern. So a tophi is an aggregate of urate crystals surrounded by inflammatory cells, foreign body giant cells. And then third is that you could have tophi in extra-articular sites, so outside the joints. And then fourth is your urate nephropathy. So you could have crystal formation, which you can see in urinalysis inside the renal tubules. So in the leftmost image, we have a joint aspirate from acute gout arthritis. So we can see you have needle-shaped urate crystals inside the neutrophils. And then here in the middle picture is a picture of a gouty tophus. This is an aggregate of urate crystals surrounded by reactive fibroblasts and inflammatory cells and giant cells. So ito yung urate crystals, the reactive fibroblasts and inflammatory cells. And then here in our rightmost picture is a picture of needle-shaped urate crystals, which are negatively birefringent under polarized light. So if we have gout, we have pseudo-gout, which now is due to calcium pyrophosphate crystal deposition. So yung calcium pyrophosphate, they will form bulky, white, friable deposits. And instead of being needle-shaped, they are rhomboid-shaped and positively birefringent crystals. Compared to gout, mas mild yung inflammation that we see in pseudo-gout. So patients frequently are asymptomatic, but they commonly affect the knees, the elbows, the shoulders, and the ankles. And then on X-ray, you see chondrocalcinosis. Okay, so moving on to our joint tumors and tumor-like conditions, we have ganglion cysts, which are small, firm, fluctuant nodules, almost always near a joint capsule or tendon sheet. So we frequently see them near the wrist. These are cystic or myxoid connective tissue degenerations na nag-accumulate. And then you also have your synovial cyst, which is herniation of the synovium, or a massive enlargement of a bursa. And then when we see them in the popliteal area behind the knee, we call that a Baker cyst. So moving on to our soft tissue lesions, first we start with tumors of adipose tissue. So we have lipomas, which are the most common soft tissue tumors in adults. So lipomas are benign, well-differentiated masses that grow in the trunk or proximal extremities. This is in contrast with a liposarcoma, which arises from deeper soft tissues of the proximal extremities pa rin, pero also now in the retroperitoneum. So liposarcomas have a tendency to recur in contrast to your lipomas. Next is skeletal muscle tumors, most commonly characterized by a rhabdomyosarcoma, which is malignant in nature and aggressive. The common sites are the sinuses, the head and neck, and the genitourinary tract. So we have different subtypes, the embryonal and alveolar types, which are soft tissue sarcomas of childhood and adolescence. And then we have your pleomorphic subtypes, which we see in adults but is more fatal. Notable variant of embryonal subtype is the sarcoma botryoides. So these develop in walls of hollow mucosaline structures like your nasopharynx or your vagina, and it actually confers the best prognosis. So sarcoma botryoides gets that name because it looks like a bunch of grapes. Okay, so here in our histology, the top picture is the embryonal subtype. So you have malignant cells na iba-iba yung itsura niya. Yung iba mukhang round, na densely eosinophilic. Tapos yung iba mukhang smooth muscle or skeletal muscle in differentiation. And then here in bottom, we have the alveolar subtype. So it gets that name kasi mukha siyang yung alveoli natin sa lungs. So you have this cohesive, uniform, round tumor cells. And then last we have our smooth muscle tumors, which is the leiomyoma, which is the most common neoplasm in women, often found in the uterus. So we have densely eosinophilic spindle-shaped cells that intersect each other at right angles. And then the more malignant version of this is the leiomyosarcoma, which are deep soft tissue tumors of the extremities and the retroperitoneum, parang liposarcoma. So these are painless masses with hyperchromatic nuclei arranged in interweaving fascicles. Okay, so for our last topic today is the pathology of peripheral nerves and skeletal muscles. So let's start with our peripheral neuropathies. These have many types, but the more common ones are your inflammatory, which is characterized by your GBS or Guillain-Barré syndrome. So these patients have a history of prior infection, most commonly by Campylobacter jejuni, which causes gastroenteritis, CMV, EBV, or mycoplasma. So it's due to an immune-mediated demyelinating neuropathy. So na-demyelinate yung nerves. These are caused by activated macrophages, and they present with ascending paralysis and areflexia. And then next we have our infectious causes of neuropathies. Some examples include shingles caused by varicella zoster. So dermatomal involvement siya na painful. leprosy caused by Mycobacterium leprae, which infects the distal extremities and the face. Lyme disease, again, by Borrelia burgdorferi. So these present with polyradiculon neuropathy. So maraming nerve roots yung affected, as well as facial nerve palsy or your Bell palsy. And then last, we have HIV, which causes mononeuritis multiplex, or in chronic cases, a distal sensory neuropathy. Another common cause is a metabolic cause like diabetes. So may peripheral neuropathy in a glove and stocking distribution. So mas naunang na-affect yung mga distal fingers and toes. Uremia also presents with distal symmetric neuropathy as well as vitamin deficiencies like your B6 deficiency. And then we have physical causes of neuropathies commonly caused by trauma or entrapment. So dito under si carpal tunnel, like dito sa median nerve entrapment, and your mortoneuroma, which occurs in the foot. Okay, so next we have diseases of the neuromuscular junction. Yung two most commonly discussed is myasthenia gravis and Lambert-Eaton myasthenic syndrome. So they are both immune-mediated, caused by antibodies to different targets. So kapag myasthenia gravis, you have antibodies to your postsynaptic acetylcholine receptor. Pero kapag Lambert-Eaton syndrome, you have antibodies against your presynaptic calcium channels. So these present differently then. With myasthenia gravis, you have easy fatigability with repetitive use of the muscles. And then most commonly, you see this first like in the eye. And then kapag Lambert-Eaton naman, it actually improves with muscle use. So these you can see in the proximal muscles. So myasthenia gravis is also associated with thymic abnormalities, the thymus, such that sometimes myasthenia gravis can be a manifestation of a thymoma or a mass of thymic origin. Okay, so for Lambert-Eaton naman, it can be a paraneoplastic disorder associated with lung cancer. And then next, we move on to our inflammatory myopathies. First is dermatomyositis. So this is an immunologic disease that damages small blood cells. So when the blood vessels are damaged, you get telangiectasias or capillary dilatation, most prominently in the nail folds, in the eyelids, as well as the gums. So you have a slow onset symmetric muscle weakness that affects the proximal muscles, as well as myalgia or muscle pain. So here we have the heliotrope rash affecting the eyelids. And then histologically, there is perifascicular atrophy, as well as inflammation here. And then we have Guthron papules, which are another epidermal manifestation of dermatomyositis. And then next we have polymyositis, which is CD8-mediated inflammation. So it presents similarly to dermatomyositis. So you have muscle pain and weakness, pero wala kang skin features. And in contrast to dermatomyositis, the inflammation is endomysial in location, so inside the muscle fascicle. And then third, we have inclusion body myositis, which commonly affects the elderly and commonly affects the quads and distal upper extremities. So kapag inclusion body myositis, under special stains, you can see these inclusion bodies inside the muscles themselves. So these can be composed of beta amyloid, TDP43, or ubiquitin. So next, let's discuss our muscular dystrophy, starting with our X-linked Duchenne and Becker muscular dystrophies. So these are diseases that have mutations that disrupt dystrophin function. So ano ba yung ginagawa ng dystrophin? It stabilizes the muscle fibers and their cell membranes during muscle contraction. So kapag wala kang dystrophin, your muscle fibers are more vulnerable to damage. This leads to progressive weakness and muscle wasting as the child grows older. And then they also present with pseudo-hypertrophy of the calf muscles and Gower's sign, wherein the child has difficulty standing from a sitting position because of weakness of the proximal muscles. So dystrophin is also expressed in the heart and the CNS. So for patients with Duchenne, which is a more severe form of the disease with complete absence of dystrophin, patients commonly succumb at before 30 years old, usually due to respiratory insufficiency or heart failure. And then here we have two biopsy specimens from two brothers with Duchenne muscular dystrophy. So dito sa 3-year-old brother in the leftmost, you can see that it looks almost normal. Pero in immunohistochemical stains, there is absence of dystrophin, complete absence. Kasi normally, normal muscle should look like this. That's dystrophin surrounding the myofibers. Pero here in our patient, there is complete absence. And then in the rightmost is the biopsy specimen from his 9-year-old brother. So we see a more advanced version of the disease. So halos wala ng myofibers. Instead, it's replaced by fibrosis and inflammation. Next, we have our myotonic dystrophy, which is now autosomal dominant in inheritance. So you have CTG nucleotide repeats, and this presents with weakness, cataracts, endocrine dysfunctions, and cardiomyopathy. Okay, so now we have our peripheral nerve sheath tumors. Let's start with our schwannoma. Schwannomas are well circumscribed encapsulated masses attached to an associated nerve. So what we commonly know is cranial nerve 8, which is located at the cerebellopontine angle. And then histologically, you see Antoni A and Antoni B areas. So itong mas dense na pinkish eosinophilic area, that is your Antoni A. And then the looser pale Antoni B areas. And then if we zoom in into Antoni A areas, we see tumor cells aligned in palisading rows. So you have anuclear zones and structures which are termed Verroquet bodies. And then next we have neurofibromas, which are nerve sheath tumors of neoplastic Schwann cells combined with perineural-like cells, fibroblasts, mast cells, and CD34 plus spindle cells. So it's due to complete loss of neurofibromin, and then there are several types. Of note is the plexiform type, which looks like a bag of worms or shredded carrots. So these are bland spindle cells admixed with your wavy collagen bundles. And then you have your malignant peripheral nerve sheath tumor, which are poorly defined tumors, assumed to result from malignant transformation of a plexiform neurofibroma. So these tumors affect the larger peripheral nerves found in the chest, in the abdomen, the pelvis, the neck, or the limb girdle. And then last we have neurofibromatosis, which arise from mutations in your NF1 and NF2 genes. So we have two types, type 1 and type 2. So kapag type 1 neurofibromatosis, NF1 mutation, which produces neurofibrin. So this gene is in your chromosome 17. So type 1 NF1 chromosome 17, may 1. This is also called von Recklinghausen disease, and it presents with multiple cafe au lait spots, multiple neurofibromas, and Lisch nodules in the eye. Okay, compared to your type 2 neurofibromatosis na NF2 mutation naman. So NF2 produces myelin. This is found in your chromosome 22. It's called central neurofibromatosis because it manifests with bilateral acoustic neuromas. So again, type 1 neurofibromatosis, NF1, chromosome 17, and F type 2 is NF2, chromosome 22. Okay, so that's it for endocrine, skin, bones, joints, soft tissues, and peripheral nerve pathologies. Thank you for your attention. I hope you learned a lot in this quick run-through that will help you in your clerkship and internship life. If you have any questions, don't hesitate to reach out. Pakilala lang kayo. And most importantly, well, good luck, have fun, and stay safe. Stay safe.
All right. So, hi guys. And so welcome back again to another episode of Genesis Pathology. So we're down to the last two topics under your pathology, no? We're going to discuss your CNS pathology and your ano ay last? Eye pathologies. Okay, let's start with CNS pathology. So, ito yung brief overview ng dadaanan natin: stroke, CNS trauma, CNS infections, neurodegenerative disorders, and tumors. Okay? And as similarly dun sa diniscuss natin earlier, no, about the kidneys, ganun pa din, no. I-present ko yung clinical picture and then I will always give some pathological keywords or buzzwords na kailangan nyo maalala kasi ganun naka-present yung ating patho. Okay? Ganun naka-present yung mga questions sa patho. Okay? They give a clinical scenario and then you have to diagnose it. But the question is about the pathology itself. Okay, so let's start with your ischemic ischemic brain disease or stroke. Okay, so for stroke, no, remember the mnemonic, no, vulnerable hippos need pure water. Okay, vulnerable hippos need pure water. So hippos means hippocampus, need means neocortex, pure means your Purkinje cells. Water means watershed areas. Again, hippocampus, neocortex, Purkinje cells, and watershed areas. So remember that those four are the most vulnerable areas. Okay? That is associated with ischemia of the brain. Okay? So when we talk about when we talk about ischemia and stroke, no, anong type of necrosis yung nag-form or anong type of necrosis yung or pattern of necrosis yung makita natin? It's liquefactive or coagulative? It's liquefactive. Remember, di ba, in basic pathology? And what are the different types of stroke that can present in a patient? It can be thrombotic, no? Pwedeng merong ruptured atherosclerotic plaque tapos dun dahil nasira yung blood, yung membrane, di ba, yung endothelial layer, pwedeng magkaroon ng clot formation. So pwedeng thrombotic, di ba? Pwedeng embolic, no, from another part of the body, no? Tapos nag-throw off yung, for example, a clot going to the brain. Okay? Pwede ring hypoxic, ibig sabihin kumonte yung oxygen level. So for example, sa mga cardiovascular surgeries, ganyan, no? So pwedeng hypoxic. And all of these three can cause stroke. Okay? So what do you call naman an ischemic disease that resolves within 15 minutes? Okay, kunwari nagka-manifestation of stroke, ganyan, pero nawala within 15 minutes, you call that as your transient ischemic attack. Okay? In the ER, no, kung may nakita na kayong ganito, nag-present siya with stroke, tapos maya-maya, okay na siya. Okay, nakakalakad na siya ulit. No? So that is your TIA. Okay? So let's now move to the intracranial hemorrhage. So as you can see, no, nagbigay ako ng clinical picture dito sa baba na part ng slide. So sabi natin, for example, you are in the ER, nagkaroon ng motor vehicular accident, a traumatic accident, and the patient presents with a transient loss of consciousness. Tapos bigla, naging okay siya. Okay? Tapos bigla, nag-deteriorate siya bigla. Okay? Buzzword yon. Okay? For what impression? Your epidural hematoma. Okay? May transient loss of consciousness, magiging okay, and then rapid deterioration kasi biglang nag-expand yung hematoma pa, okay, sa loob. So that is epidural hematoma. Which area of the skull is usually associated with your epidural hematoma? It's your terion. So it's one of the thinnest area ng ating skull, no? As you can see, dyan sa may side ng ating brain, head, dito sa part na to. So this is where the terion is found. Okay, what is the vessel? Daming bulol ngayon. Vessel associated with with your epidural hematoma, it's your middle meningeal artery. Recall nga sa anatomy, saan lumalabas yung ating middle meningeal artery? Sa ating foramen spinosum. Okay? So what is the shape of the hematoma in your intracranial, in your epidural hematoma? Diba ganyan yung itsura niya? So it looks like a biconvex na lens, diba? Leaf shape, biconvex. Okay? So as you can see dun sa picture, does it cross suture lines? Does it cross suture lines? It does not cross any suture lines. So later on, madi-differentiate natin ito the next pathology. Okay. Next pathology, kunwari, binigyan lang kayo ng CT scan. Okay? Anong itsura nung hematoma? It's crescenteric shape, no? Ang primary impression mo dyan should be subdural hematoma. And the vessel associated with this are your bridging veins. Okay? Your bridging veins nanggagaling sila sa subarachnoid layer, tapos dadaan sila, pipierce nila yung, kunwari ito yung dura mater mo, ipipierce nila yung dura mater para makapasok sila sa dural venous sinuses. So for example, itong layer na to, ito yung subarachnoid layer, kunwari subarachnoid space. Mas ito yung bridging vein. Okay? So tingin kayo sa video ko saglit. So ito yung bridging vein, ito yung papasok doon sa dural venous sinuses, no? Piercing the dura mater, no? Ito yung tinatawag na bridging vein. So ibig sabihin, kapag yung brain ninyo ay atrophied na or kunwari naalog yung brain, pwedeng maggalaw yung bridging veins. So pag naggalaw siya, nausog siyang with a high impact force, or minsan nga sa elderly, pwedeng kahit low impact force lang. Pero dahil atrophied yung cortex nila, pwedeng naaalog yung brain, no? So pwedeng mabali yung bridging veins. Hence, it will present with subdural hematoma. So I hope it's easy to remember, no, pag na-imagine niyo siya. Okay? So look at my video earlier, you rewind it para mas maalala niya. Okay? And then shape nito, nabanggit na natin, crescentic, no? Pagka subdural hematoma. Okay? So yung unang dalawa, laging nalilito yung mga tao. Crescent is subdural. Biconvex shape is your epidural. Middle meningeal kapag ka epidural. Bridging veins kapag ka subdural. Kaya ko sila pinagtabi. So kung si epidural does not cross suture lines, your subdural hematoma, they cross suture lines. Okay? Next. Ay, nakasulat na. So, kunwari, yan yung manifestation. Sabi niya, Doc, sobrang sakit po ng ulo ko. Pero siyempre, pag sobrang sakit, hindi na siya makakapagsalita. Sobrang sakit po ng ulo ko. Ito po yung pinakamasakit na headache ko ever. Okay? So, worst headache of your life, think of subarachnoid hemorrhage. And speaking of subarachnoid, di ba? Subarachnoid space, ano yung nilalaman ng subarachnoid space? You have your CSF. So, that is continuous down to your spinal cord, di ba? So hence, kapag nag-bleed ka, for example, sa subarachnoid space, ano kaya makikita mo sa lumbar tap findings? Pwede siyang may bloody tap or a yellow colored na tap. No? It's your xanthochromatic tap. Okay? So, and usually, ang ating subarachnoid hemorrhage is associated with aneurysm rupture. Okay, aneurysm rupture. And the most common location of aneurysm is where? Sa junction ng ACA, okay, your anterior cerebral artery and your anterior communicating artery. Okay? So, ating mga different types of hemorrhages. So, ano naman yung mga different effects of stroke? So, it depends actually on where on what vessel is affected, no? Actually, ito papakita lang natin, no? Just a brief overview. Okay? So you have to memorize the motor homunculus, no? And the somatosensory homunculus for you to be able to differentiate, no? Kung sino yung mga affected structures or affected body parts, no? Makita nyo dito sa my right side natin, okay? So ito yung lateral views. Nasa gilid tayo, for example. So dito yung middle cerebral artery, the one shown in red, no? Okay? Diyan pumupunta yung MCA. Tapos si ACA, okay? Kunwari, hinati mo yung brain. Di ba dalawang hemisphere yung brain? Hinati mo yung brain, okay? Titignan ko siya dito. Okay? Ito yung medial view ngayon. So therefore, yung ating anterior cerebral artery, dumadaan siya papunta dun sa loob. Okay? And kapag papattern mo siya dito sa dun sa picture on the left, okay? Yung lower extremities are found in the midline portion supplied by your, ano nga ulit? Anterior cerebral artery, while those in the lateral portions of the brain, okay, will present with upper extremity weakness, facial weakness, kasi supplied by your MCA. Pagka sa likod naman ng brain or the posterior part, posterior cerebral artery yung nagsusupply, and usually dyan ang affected dyan ay mga vision, okay? Yung vision natin. Okay? So those are the parang general effects of stroke. Okay? So naka-present na siya. Hindi ko siya nalagyan ng animation. Okay? So, face and upper limbs dun sa motor homunculus, okay? Anong territory? MCA. Okay? Kapag ka MCA territory, di ba, meron ka kasing dominant and non-dominant hemisphere. Usually, the left is a dominant. Pag affected ang dominant hemisphere mo, meron kang associated na aphasia. Pero pagka non-dominant hemisphere, remember, there can be a presentation of hemi-neglect. Okay? Pagka ACA territory naman, okay, sabi natin kanina, dun siya sa midline. Ano yung affected? The lower limbs, di ba? Contralateral lower limbs, ACA. Pero pagka vision yung affected, PCA territory. Pero syempre, neuro has a lot of intricacies. No? These are just generalities that you have to remember para madali nyong maisip kung ano kaya possible na associated pathology. Alright? Sige. So, next, tapos na tayo sa stroke. Na tayo sa CNS infection. Okay, for your CNS infection, pwede tayo acute pyogenic, acute aseptic, or TB, meningitis. Okay? For CNS infection pala ang i-discuss natin, the most common, no, yung mga meningitis questions. No? So, causes ng meningitis in infants, 'di ba? We have your E. coli, GBS, 'di ba? Kaya nga may GBS screening, 'di ba? And E. coli, remember, para hindi niyo makalimutan, it's part of the normal flora of the vaginal tract of your mom. So pag nilabas yung baby doon sa doon sa puwerta ni mommy, syempre na niya yung mga E. coli na nandyan at GBS, no? So it can cause meningitis. And adolescent, think of Neisseria meningitidis. Pag elder naman, think of strep pneumoniae. Okay? Pag acute aseptic, think of viruses. The most common is enteroviruses. Okay? The most common is enteroviruses. You can also consider rickettsia, pero it's a rare consideration. No? TB meningitis, of course, is caused by your M. tuberculosis. Okay. Ano naman yung mga cells na associated? Dahil bacteria yung acute pyogenic, neutrophils yung makikita mo. Pagka viral, syempre lymphocytic. Okay? And mononuclear pagka TB meningitis. Because macrophages yung di ba? And cells, yung mga cells na makikita nyo sa MTB. Okay? And then, the sugar, okay, ni-read ko na dyan yung low, kasi pag low sugar, think of bacterial. Pero pagka protein naman, very high naman, ni-read ko din dyan, TB meningitis, okay? So yan yung mga very important things to remember, okay? For your meningitis. Okay. Now let's go to the neurodegenerative disorders. Okay? For your neurodegenerative disorders, okay, ginawa ko ulit, clinical, and then you give me the primary impression. Okay? Then I will just discuss a bit of about pathology na important na kailangan tandaan. Okay? So kunwari, the patient presents with tremors, nanginginig, or kunwari meron siyang usually kasi sa adults na to, sa elderly people na makikita to, no? Kunwari yung anak niya, sabi ng anak niya, si mama niya, parang laging hindi makagala, ay parang laging nanginginig, ganyan. Tapos matigas yung movement, no? So rigidity. Akinesia, so hirap siyang mag-start ng voluntary movement. Postural instability, okay? Mahirap siyang maglakad or mas ma-maintain yung kanyang posture. Shuffling gait means yung parang yung lakad niya is ganito lang. Parang sa pangalan, Lotus Feet, yung sa sukob na movie, di ba? Shuffling gait yun. Yun yung lagi ko naalala. And then small handwriting. So your primary impression for this condition should be your Parkinson's disease. Okay? Pagka Parkinson's disease, what is the affected part in the brain? It's your substantia nigra. And ano yung neurotransmitter na secreted by your substantia nigra? It's your dopamine, di ba? Mababa yung dopamine mo dahil kaya ka nagkakaroon ng Parkinson's disease. Okay? So, that's for your Parkinson's disease. Next, kunwari, a patient presents around 20 to 50 siya. Presents with chorea, athetosis, aggression, depression, tapos dementia. Tapos, nalaman mo sa nag-conduct ka ng family genogram, no? May earlier manifestation dun sa mga subsequent generation, meaning yung anak niya, kunwari siya, nagkaroon siya ng ganitong presentation 50, yung anak niya nagkaroon ng ganitong presentation 40, okay? And then 30 yung susunod, no? Ito, you can consider now a primary impression of Huntington's disease. Okay? Huntington's disease. What is the pathology behind Huntington's disease? Diba? It's a trinucleotide repeat of what? Ang tawag doon? Trinucleotides? Trinucleotide repeat of CAG. No? CAG. Ang palatandaan ko dyan, hunt. Diba? Hunter, meron silang baril. Tapos pagka bumabaril siya, anong tunog ng baril, di ba? Kag, 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 ganyan, okay? So, kag, kag, kag for Huntington, okay? What chromosome is associated with Huntington's disease? It's your chromosome number 4, okay? If you spell Hunt, okay, it has 4 letters, H-U-N-T. So, chromosome 4. And which structures are affected? It's your caudate and putamen. The neurotransmitter involved in this one is ACH and GABA. So para ma-remember ninyo, no, CAG, di ba? Sabi ko kanina, CAG, trinucleotide repeat, C for caudate, A for ACH, G for GABA. Okay? So CAG, 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 Huntington. Okay? And then, for example, the patient presents with dementia, the patient is an elderly, okay, and it's also associated with, this condition is also associated with Down syndrome. The primary impression is Alzheimer's. Nung boards namin, ang daming tanong about Alzheimer's. Kasi tinanong siya sa biochem, tinanong din siya sa anatomy, ganyan, and other, as in halos, not naman lahat, pero madaming tanong about Alzheimer's. Yan. So, I think it's the disease of the year ng recent boards, no? So, Alzheimer's. So, in the pathology of Alzheimer's naman, pag senile plaques, ang buzzword na kailangan nyo maalala dyan is yung beta amyloid, no? Beta amyloid. Pag neurofibrillary tangles, no? T for tau, okay? T for tangles, T for tau. But the difference between beta amyloid and your tau protein ay extracellular component, yung ating mga beta amyloid. Okay? Tau protein ay intracellular. Okay? What structure naman yung affected kapag Alzheimer's? Yung ating cortex. Nagkakaroon ng cortical atrophy. What neurotransmitter? Your acetylcholine. Okay. So, patient presents with visual hallucination, dementia, and Parkinsonism. Okay? Primary impression, Lewy body dementia. Okay? Ang palatandaan ko dyan ay hallucination. Okay? So, dementia plus hallucination, it's your Lewy body dementia. Okay? So, the affected structure is your cortex. No? Meron kang accumulation of your intracellular Lewy bodies. Alright? So tumors naman tayo na CNS. So generalities, ang location ng tumors sa children ay infratentorial. Ang palatandaan ko dyan ay mas maliit yung mga bata kaysa sa adults na supratentorial yung location. Ay mas mataas. Okay, asan ba yung supratentorial and infratentorial? 'Di ba sa ating brain nakadivide siya into upper supratentorial and lower the infratentorial by the tentorium cerebelli. Okay? So yon. So adults the most common tumor in the brain is metastasis. Okay, don't forget that. But the most common primary tumor is your glioma. Okay, your glioma. And remember clinically no yung mga tumors natin, they are usually related parang yung mga symptoms niya hindi naman parang yung symptoms niya ay related to a mass effect, no? Remember the Monroe-Kelly doctrine, di ba? That governs yung pressures inside the brain, di ba? So, it's usually the symptoms is usually related to mass effect or kunwari merong compressed structure, compressed nerve, no? Ganun yung manifestation ng tumor, no? So, think of associated anatomical landmarks, no? Surrounding the tumor for you to be able to distinguish kung ano kaya yung clinical presentation ng patient. So let's go to the tumors one by one. So pag glioblastoma multiforme, okay? So buzzword, no? Butterfly glioma kasi it can cross, as you can see in the picture, no? It can cross from one hemisphere to another through the corpus callosum. Okay? There's also pseudopalisading. Okay, ito yon, may kita na ito. So pseudopalisading area. Yeah. So that is for your glioblastoma multiforme. For your oligodendroglioma, okay? Remember, based sa term, sa pangalan, oligodendrocytes, diba? Yun yung may fried egg appearance, oligodendrocytes. So, kaya ang itsura niya, fried egg cells. As you can see sa picture, mga fried eggs, diba? And, okay, may kita sila usually sa frontal lobe. Okay? Frontal lobe. Ito medyo green na joke, green na mnemonic, no? Pero if you do a frontal, okay, you will see an egg. Okay? Pag male. Okay? So if you do a frontal, you will see an egg. So for you to remember, fried egg appearance, oligodendroglioma, and frontal lobes yung usually affected. Okay? It's also associated with chicken wire capillaries. Okay, next. Meningioma. For meningioma, so think of, pag narinig yung spindle cells, whorled cells, okay? So makikita nyo yan, no? Para silang spiral, whorled, okay? Spindle, meaning parang thin appearance, no? So meningioma, think of meningioma. So it's also associated with samoma bodies, meningioma. Yeah. So meningiomas, yung samoma bodies, and ang appearance ng mga meningioma usually malapit sa periphery. Okay? Kasi nandun yung mga meninges natin. Alright? Okay. Just a quick rundown of the other adulthood CNS tumors. Pituitary adenoma can present with, what do you call this? Your bilateral, okay, hemianopsia. Diba? Hemianopsia. Okay? So, bitemporal hemianopsia. Okay? So, yung temporal areas mo, wala ka nakikita. Okay? So, bakit? Kasi yung pituitary gland mo, diba, malapit siya sa optic chiasm. And if it impinges on that, what happens? Okay? So, bilateral hemianopsia. Bitemporal. And then, schwannoma, ito, natanong siya sa, if I'm not mistaken, PrevMed din ata. Random questions in PrevMed. No? Schwannoma, remember, okay, it's a tumor found, no, dun sa cerebellopontine angle, no? Cerebellopontine angle. And, di ba, dun sa pangalan, cerebellopontine, nasa may pons area siya. And ano yung mga cranial nerves na lumalabas sa pons area? It's your 5, 6, 7, 8, di ba? Kasi di ba sa midbrain, 3, 4. Sa pons, you have 5, 6, 7, 8, di ba? So, 5, 6, 7, 8. So, pasok doon yung ating 7 and 8. So, ano yung mga usual presentation ng patients na may schwannoma? So, mga tinnitus kasi impinges on the vestibular nerve, no, yung cranial nerve 8. So, mga ganong types of questions. So, schwannoma, cerebellopontine. Okay. Childhood primary tumors. The most common primary brain tumor is your pilocytic astrocytoma. Okay. Rosenthal fibers. Ang mnemonic ko dyan is pile of roses. Okay. Pile of roses. Okay. Most common malignant brain tumor is your medulloblastoma. Okay. Homer right rosettes. Okay. Medulloblastoma, Homer right rosettes. So as you can see, the last two pictures yan yung mga Homer right rosettes. So, and the Rosenthal fibers are those seen in the arrow dun sa letter B. Okay? So, most common supratentorial childhood tumor is your craniopharyngioma. Okay? It is a derivative of your Rathke's pouch. No? And ang manifestation nito para siyang si pituitary adenoma. Bakit? Kasi si Rathke's pouch, di ba, if you remember sa anatomy, if it extends upward, it becomes your anterior pituitary. So if naging tumor yung mga cells from the Rathke's pouch, para siyang naging tumor ng pituitary. Okay? But it came from the cranial, it's called craniopharyngioma. So it's usually mistaken as a pituitary adenoma. Pero ang clincher, to differentiate it with your pituitary adenoma is meron siyang motor oil na parang cytoplasm, parang fluid surrounding the tumor. Okay? So next, buzzwords. Causes Parinode syndrome or Parinode syndrome is your pinealoma. Okay? So P for Parino, pinealoma, P for pinealoma. Okay? And then lastly, okay, we're almost done. The eye pathologies. So yung mga eye pathologies, just quick rundown of the different important things to remember. No? Pag farsightedness, okay, it's called hyperopia. Ang palatandaan ko dyan is hyperopia. And you correct it by, later pa pala yung correction. Nearsightedness ay myopia. Okay? So, syempre kung hyperopia, opposite niya ay myopia. So, basta remember, hyperopia. Okay? Farsightedness. And then, different refractive powers. Okay? Meaning, yung isang part nung lens ay iba yung refractive power. And then, yung isang part nung lens ay iba na naman yung refractive power. That's called astigmatism. Okay? Pero one single eye pa rin yun. Alright? And how do you correct your hyperopia? Okay? You use convex lenses. So para mas maalala ninyo, kasi di ba pag hyperopia, ang image mo ay seen, di ba? Dito. Okay? And yung convex lens, pag ganito siyang lens, di ba? Ang light, pag dumaan siya sa isang convex lens, magma-merge or magko-converge yung light. Okay? Therefore, pag ginawa mo yun, mapapa-converge mo at an earlier, okay, nang mas maaga yung light. So, magfo-fall siya ngayon doon sa inyong retina. Kaya convex lens. Pero pagka concave lens, okay, pag myopia kasi, di ba, nearsightedness. So, yung image nagpo-form in front of the retina. For example, this is the retina. Okay? Pag concave lens, ang nangyayari, di ba ganyan yung concave lens? Ang nangyayari is, yung light, naghihiwalay. Okay? So therefore, para mapalayo mo yung image, gusto mong magbigay ng concave lens para pumunta ng mas malayo yung image dun sa may retina. So, nagets ba yun? So, just a quick graphical presentation, I mean, of the different refractive errors. Okay? Pagka astigmatism, you use cylindrical lenses. Okay. So for glaucoma naman, okay, for glaucoma, it's ang keyword dyan is atrophy of the optic disc due to an increased intraocular pressure. Okay? So differentiate natin ng open versus closed angle. Pag sinabing open, okay, open angle, kunwari ito yung ating kunwari ito yung eyes. Okay? Kunwari yung eyes, tapos ito yung iris, tapos ito yung pupil din sa gitna. Yan. Okay? Pag sinabing open angle, remember that your fluid, di ba? Your aqueous humor, pumupunta siya, papunta dun sa anterior chamber and magdre-drain siya dito sa sides. So, pagka open angle, so based sa name, no? Open angle, bukas itong side na to para mag-drain siya. Pero, ang problem, mataas pa rin yung ICP. Okay? IOP, intraocular pressure, kahit na bukas yung angle mo. Pero pag close angle, okay, masyadong masikip. Yung iris mo, para siyang gumanyan. So, sobrang sikip nung area na dadaluyan nung fluid. So, that is closed angle glaucoma. Hence, hindi nagde-drain ngayon yung ating fluid kasi naka-block. Okay, so that is the difference between open angle and closed angle glaucoma. Okay? Tapos meron din tayong tinatawag na acute angle closure glaucoma, yung bigla-bigla na lang nag-red yung eyes, okay? Kasi biglang nagkaroon ng closure nung exit, okay? Yung opening nung ating drainage. Okay? So those are your different types of glaucoma. Punta naman tayo sa retinal pathologies. So, differentiate lang natin, no? There DM retinopathy and hypertensive retinopathy. So, the two most common causes ng blindness, di ba? Na associated with your different conditions na hypertension and diabetes. So, two types of DM retinopathy. We have your non-proliferative and your proliferative. Okay, pag non-proliferative, okay, nagkaroon lang ng leakage ng nasira lang yung blood vessel, nag-leak yung blood, okay? Pero walang nag-grow. Based sa name, no? Walang nag-grow na new blood vessels. So that is non-proliferative. Pero pag proliferative, okay, there's new growth, new vessel growth. Okay? Retinal findings naman in hypertension, cotton wool spots, flame-shaped hemorrhage. Cotton wool spots is the one shown in blue arrow. No? This one. Okay? Tapos, flame-shaped hemorrhages and your flame-shaped hemorrhages. And then, next we have your retinal vein occlusions and your retinal artery occlusions. Kapag dyan sa dalawang yan, I want you to remember that CRAO or central retinal artery occlusion is an ocular emergency. Okay, dyan sa dalawa, CRAO. Okay? Crow, crow, crow. Yung palatandaan, para siyang sounds like an ambulance. Crow, crow, crow. Okay? It's an ocular emergency. So it presents with an acute painless monocular vision. May cherry red spot ka. Okay? And it's associated with carotid atherosclerosis, mga cardiac vegetations, and patent foramen ovale. Okay? Ibig sabihin nun, kapag ka nagka-crow yung person, okay, think of an embolus coming from carotid atherosclerosis or may natanggal na vegetation from the cardiac, kunwari sa heart ng pasyente, or may embolus na dumaan dun sa ating patent na foramen ovale, then going to the systemic circulation. Right? While you differentiate it with your retinal vein occlusion, which presents with blood and thunder appearance, and is associated with nearby arterial atherosclerosis dun sa eyes. Okay? So, and that's it. So, that's the end of Genesis Pathology. No? I hope you learned a lot from the different lecturers, no? Na nag-discuss. And I hope you learned a lot then as well in the CNS and eye pathologies. Again, lagi ko sinasabi na mag-aral na mabuti, hindi para pumasa lang, no? Mag-aral na mabuti para maging magaling na doktor. Okay? I wish you all the best. Good luck, guys, and stay safe. Enjoy the process.